So actually, we go back about 25 years ago. And that's when we selected B cells as a target for systemic lupus and also lupus nephritis. And the drug that we used was rituximab, which, as everybody knows, is an antibody to CD20. And though the LUNAR trial, which was the study in lupus nephritis, specifically proliferative lupus nephritis, failed, there were a lot of signals suggesting that that strategy actually was probably a reasonable strategy. And the signals that we saw, number one, is that there were fewer patients who received rituximab that needed rescue therapy. In fact, it was something like 7 versus 0, as I recall. If you go beyond the primary endpoint, which is at 1 year, and just look at reduction in proteinuria, rituximab worked. So though statistically the study failed, even though there was numerical superiority of rituximab, there were signals that B cell depletion was effective. So the next key piece of information actually came from several areas. It came from a post hoc analysis of the LUNAR trial, but it also came from studies being done in England in rheumatoid arthritis and also in systemic lupus. And the message was that more B cell depletion yields better clinical responses. So it's recognized that not everybody depleted their B cells to the same degree with rituximab. And though personally I'm not a more is better kind of person, I think with B cell depletion, more is in fact better. Now, there was another study done with a different B cell depleting agent after rituximab, and that was with ocrelizumab, but there were problems with infections, especially over in Asia. So the question was posed probably about 8 or 9 years ago. I may be losing my sense of time. Whether more B cell depletion with a new antibody called obinutuzumab might yield better results in lupus nephritis. And so when I was asked that question, I said, yeah, go for it. And in fact, obinutuzumab was approved as far back as 2013 for chronic lymphocytic leukemia. And if you look at in vitro data, in vivo data, there was no question that obinutuzumab was a more potent B cell depleter than rituximab. Now, how did they achieve that? Well, they changed the sugar groups on the antibody, so that allowed for greater antibody-dependent cytotoxicity, so greater B cell killing via that mechanism, as well as just better direct B cell death. So the bottom line is that obinutuzumab came along as a much better B cell depleting agent. And the ultimate, prior to studying lupus nephritis, was studying B cell malignancies, comparing rituximab to obinutuzumab. And obinutuzumab was better. So we did the nobility trial, which was a phase 2 trial in lupus nephritis, and it was modeled after the LUNAR trial of rituximab in lupus nephritis. Now, just like in LUNAR, nobility recruited patients with proliferative nephritis, and they could have pure proliferative or combined proliferative and membranous. And the reason that that's important is when we start talking about the BLISS-LN trial. So the short of it, nobility was a positive trial. It yielded very robust data. It was a 2-year trial. And though the primary endpoint was at 1 year, the peak effect size, which was 20 percentage points, occurred at 1.5 years. And yes, we did see greater B cell depletion, and we showed in post hoc analyses that greater B cell depletion in a subset of the nobility patients actually enhanced the clinical response. So nobility served as a foundation for the phase 3 Regency trial. And Regency kind of looked like nobility, which looked like LUNAR. So in the Regency trial, patients had to have proliferative nephritis to get in, and they've had to have had a biopsy within 6 months of a study entry. Half the group got obinutuzumab, the other half got placebo, but all received background mycophenolate and background steroids. and the oral steroids had to be tapered by month 6. The regimen was very much like how we use rituximab. That is, there were 2 1,000 milligram doses 2 weeks apart, and then that course was repeated at 6 months, and then even 6 months later. So there were 3 courses of obinutuzumab during the Regency trial, and the primary endpoint was at 1.5 years. Why 1.5 years as opposed to 1 year, which was the nobility endpoint? Well, the greatest effect size seen in nobility actually was at 1.5 years. So we figured to increase our chances of success, have an endpoint at week 76. Now, data continues to be collected after week 76, and there's an extension, but we won't go into the extension. So right now we have week 76 data that are published, and we can speak a little bit about those data. The endpoint was what's called complete renal response. And that's driven by a reduction in proteinuria to below a certain value. And that value happens to be 0.5. So what does that mean? That's a protein creatinine ratio on a 24-hour urine. And that's pretty much the threshold that for most of our studies. But in addition, one could not get worse as far as renal function. And so the metric that was used there was something called estimated GFR. And there's a formula for calculating that. Because you can't call someone a success if they reduce their proteinuria, but they go into renal failure. So there was some wiggle room there, and they could get worse by a little bit, but no more than 15% of their baseline eGFR. And of course, they couldn't be rescued with other medicines, so there were criteria in there regarding treatment failure and worsening. But the bottom line is complete renal response is driven by a reduction in proteinuria and no significant worsening in renal function. So what we saw, the top line results showed for the primary endpoint, the obinutuzumab treated group had a response rate a little over 46%. And that was about 13 percentage points better than the placebo group. And when we talk about placebo, it's never just placebo. It's placebo on top of background therapy, which, as I mentioned, was mycophenolate and steroids. So that was the primary endpoint. And then there were secondary endpoints. And there are secondaries, there were about 5 or 6 of those secondaries. The top 2 were statistically significant, and they dealt with the ability to achieve a complete renal response and also taper prednisone. It's so important to taper prednisone in any of our patients. Doesn't matter whether it's lupus nephritis or SLE, you got to get patients down to a low dose, or even better, off prednisone, because prednisone just has too many side effects. So that was the key secondary. And then a second key secondary had to do with proteinuria reduction. And that's important because we know proteinuria, or protein in the urine, can actually injure the kidney. So that's also a very important endpoint. The third secondary did not achieve statistical significance, and that dealt with improvement, or I should say attenuation of loss of eGFR, so the estimated glomerular filtration rate. So why is that endpoint important? Well, kidney survival is all about trying to attenuate your loss of nephrons and GFR over time. I mean, as we're talking right now, we're each losing kidney function little bit by little bit. And if you, on top of that, have an inflammatory kidney disease, that loss of kidney will be accelerated. So we want to try to maintain as best possible our GFR. So though it did not hit statistical significance, there was numerical superiority in the obinutuzumab group. But that was at week 76. We'll see how the week 104 data come out, because I think the longer the time, probably the greater separation between placebo and obinutuzumab. The fourth secondary is worth talking about because that had to do also with maintenance. It had to do with sort of prevention of the need for rescue therapy, prevention of treatment failure, and so forth. And though if you just look at the p-value, it was statistically significant, the rules of a hierarchical analysis tell you that you can't claim significance if the one above does not achieve statistical significance. So we can refer to it as a nominal p-value. And then there were a couple of other secondaries that did not achieve even nominal significance. Anyway, so that's kind of the efficacy. As far as safety, we do worry about B-cell depletion. And what we saw was a higher frequency of serious adverse events in those treated with obinutuzumab. And they were largely because of COVID. Now, the last thing you want to do is conduct a clinical trial of an immunosuppressive during the COVID pandemic. But unfortunately, that's what we were up against. So a lot of the infections were COVID related. And actually, if you look in the supplement of the article, you'll see a graph, a histogram that divides the adverse events into two halves, time-wise. So we looked at the adverse event rate in the first half of the study versus the second half of the study. And there were far fewer COVID-related adverse events in the second half of the study. Why? Well, we learned a lot about COVID during the COVID pandemic. We learned to recognize it, to diagnose it, to treat it, to vaccinate patients. So, but it's an important message that anybody going on an immunosuppressive should be vaccinated to COVID, to the pneumococcal vaccine. I like Shingrix for my patients. Throw in a flu vaccine. It's so important when you're immunosuppressed. And in the study, we're talking about several immunosuppressives at once. We're talking about steroids, so it was key to taper steroids. We're talking about obinutuzumab and mycophenolate. Remember, all these patients are on mycophenolate. And mycophenolate may be more of a culprit in susceptibility to COVID than perhaps obinutuzumab. So I would say those are the key efficacy and safety issues that came up with the obinutuzumab study. There will be a lot more data because a lot of people are asking, they want to see the kinetics of response. They want to see what happened with protective antibody levels. There were 60 patients who had repeat kidney biopsies. And so we'll be able to see what actually happened in the deep tissues. So a lot more data, not to mention the week 104 data plus extension data. So stay tuned.